Hi everybody, and welcome to our module on the nephrotic syndrome. Let's start by reviewing the pathophysiology of the nephrotic syndrome. The primary problem in the nephrotic syndrome is that protein is lost in the urine, and as a result there are low protein levels found throughout the body. The protein loss in the urine leads to proteinuria and frothy urine, which are characteristic findings. In addition, one of the major proteins which is lost is albumin. Albumin is very important for maintaining plasma oncotic pressure, so when albumin levels fall, the plasma oncotic pressure falls. This leads to capillary leak of fluid, and that leads to edema. In addition, the capillary leak of fluid will lower the effective circulating volume and lower the glomerular filtration rate. This activates the renin-angiotensin-aldosterone system and leads to salt and water retention, and that also contributes to the edema. When albumin is lost in the urine, the liver will try to synthesize more albumin. This will lead to the liver overproducing lipids, and that leads to hyperlipidemia, which is seen in the nephrotic syndrome, and that can lead to characteristic findings in the urine, including fatty casts and oval fat bodies. And I talk about these in more detail in the video on glomerular disease principles. Finally, two important proteins which are lost in addition to albumin are immunoglobulins. This leads to a setting where infection is more likely, so patients with the nephrotic syndrome are prone to infection. And another important protein which is lost is antithrombin 3. This leads to a hypercoagulable state and can lead to thrombosis, and the nephrotic syndrome is a classic hypercoagulable state. So the classic presentation of the nephrotic syndrome is the development of frothy urine, swelling of the ankles from edema, swelling around the eyes. This is called periorbital edema. This is a classic form of edema to occur when albumin levels are low in the nephrotic syndrome. The serum total cholesterol will be high, usually greater than 300 milligrams per deciliter, and there will be proteinuria, and the proteinuria, importantly, is usually more than 3.5 grams per day. Protein in the urine at this level is called nephrotic range proteinuria. In this video, I'll go through the causes of the nephrotic syndrome, but before I do that, let me make a very important general point about the sites of glomerular injury and how that determines whether a patient will develop the nephritic or nephrotic syndrome. The major determinant of whether a disease process leads to either the nephritic or nephrotic syndrome is the site of glomerular injury. Disease processes that damage the podocytes tend to lead to the nephrotic syndrome. The reason for this is that the podocytes are separated from blood components by the glomerular basement membrane. This means when podocytes are injured or damaged, inflammation generally does not occur. The podocytes are walled off from the blood components, so white cells and complement proteins can't reach the area of damage when podocytes are injured. This means that damage to the podocytes leads to loss of the filtration barrier only, but it does not lead to inflammation. You need glomerular inflammation to develop the nephritic syndrome, and that does not occur when you have podocyte damage. So as we will see in this video, most causes of nephrotic syndrome are related to injury of the podocytes or injury to the epithelial side of the glomerular basement membrane. The endothelial cells generally are not involved. Here's a picture to emphasize this point because it's very important. In order for blood constituents to move from the glomerular capillary into Bowman space, they must cross the three elements of the glomerular filtration barrier. Those three elements include the capillary endothelium, shown in red, the basement membrane, shown in blue, and the podocytes or epithelial cells, shown in green. The disease processes we will discuss in this video that lead to the nephrotic syndrome involve damage to the podocytes or the epithelial side of the glomerular basement membrane. Importantly, those disease processes are walled off from elements in the blood, including inflammatory cells. For that reason, they do not lead to glomerular infiltration and the nephritic syndrome. Instead, what they do is impair the barrier to proteins, and therefore proteins spill from the capillary into Bowman space, and that leads to the nephrotic syndrome. For the rest of this video, I'll go through the major causes of nephrotic syndrome listed on this slide. All of the disorders on this slide can potentially damage the podocytes or the basement membrane and lead to the nephrotic syndrome. The only one of these disorders I will not discuss is membranoproliferative glomerulonephritis. This disorder can cause either the nephritic or the nephrotic syndrome. It tends to be very confusing for students, and I have a separate short module just on this disorder. The first cause of nephrotic syndrome is called minimal change disease. This disorder is very easy to understand. What happens in minimal change disease is that the podocytes become effaced, which means flattened. When the podocytes are flattened, they do not function normally, and the filtration barrier to protein is lost. As a result, protein spills into the urine, and that leads to the nephrotic syndrome. Albumin is a negatively charged substance. Negatively charged substances are called anions, and when effacement of the foot processes occurs in minimal change disease, that leads to a loss of the anion or negative charge barrier of the glomerular basement membrane. This leads to the loss of albumin in the urine, and that leads to the nephrotic syndrome. The trigger for effacement of foot processes is cytokines. They lead to damage of the podocytes. Usually this is an idiopathic process. However, you should be aware that minimal change disease is associated with Hodgkin lymphoma, and this is very easy to remember if you understand that the pathophysiology of Hodgkin lymphoma involves massive production of cytokines by Reed-Sternberg cells. I talk about this in detail in the hematology section, but all those cytokines produced by Hodgkin lymphoma cells can potentially lead to minimal change disease. It's called minimal change disease because there are minimal changes seen on renal biopsy samples. By light microscopy, the glomeruli appear normal. There are no important findings on immunofluorescence. The only finding is seen on electron microscopy. That's where you can see effacement of the foot processes. If you look at this glomerular capillary on the bottom left side of the screen, you can see the foot processes which are sticking up straight. That's the normal appearance. On the right side of the screen is a glomerular capillary from a case of minimal change disease, and the podocytes are flattened or effaced against the glomerular basement membrane. Some other features of minimal change disease to be aware of. It sometimes has an immunological trigger days before the nephrotic syndrome develops. Remember, this disorder is caused by cytokines, so things that trigger cytokines can potentially lead to minimal change disease. This includes a viral infection like an upper respiratory infection, an allergic reaction like a bee sting, or an immunization. Another feature of minimal change disease is that the proteinuria is selective. Only albumin will be found in the urine, not immunoglobulin and other proteins. This is different from other causes of nephrotic syndrome where the proteinuria is non-selective. And then finally, you should be aware that this is the most common cause of nephrotic syndrome in children. So the classic presentation is a child with a recent upper respiratory infection who then develops the nephrotic syndrome. Minimal change disease has a favorable prognosis. It responds very well to steroids. And if you just remember that cytokines lead to minimal change disease, then it's easy to remember that steroids will help because steroids are anti-inflammatory. And this is unique among causes of the nephrotic syndrome. Most of the other causes we will discuss in this module do not have such a favorable prognosis and do not respond so well to steroids. Our next cause of nephrotic syndrome is called focal segmental glomerulosclerosis. This disorder gets its name because on biopsy samples there is evidence of glomerulosclerosis, which is pink dense deposition of collagen in the glomerulus. If you look at this image on the screen, you'll see a glomeruli at the bottom where there's accumulation of dark pink material. That is evidence of glomerulosclerosis. It's called segmental because only a portion or segment of the glomerulus is involved. Also seen in this glomerulus on the screen, some of it is normal and some of it is abnormal. Finally, it's called focal because only some of the glomeruli are involved. In this image on the screen, we've got a normal glomerulus up here and a sick glomerulus here. That is a focal disorder, and that's how FSGS gets its name. In the sclerotic segments, there is collapse of basement membranes and hyaline deposition. This is called hyalinosis. That's the accumulation of pink material you saw in the last slide. In addition, on electron microscopy in FSGS, you can see effacement of foot processes, just like we talked about in minimal change disease. So going back to that rule of thumb I mentioned early in this video, pathologic processes that lead to the nephrotic syndrome can involve the basement membranes and the foot processes, but they do not involve the capillary endothelium. Here's a summary of the renal biopsy findings. By light microscopy, you see those focal segmental lesions we saw earlier. On electron microscopy, you can see effacement of the foot processes, just like we discussed for minimal change disease. And on immunofluorescence staining, it is usually negative. That's because no immune complexes are involved in the pathophysiology of FSGS. You will sometimes see positive staining for IgM C3 or C1. This is a nonspecific finding. Just like minimal change disease, FSGS is caused by podocyte injury. However, the trigger is unknown. And an easy way to think of FSGS is as a more serious and dangerous version of minimal change disease. It involves podocyte injury like minimal change. It has effacement of foot processes like minimal change. The difference is that FSGS often progresses to chronic renal failure. It does not have a benign course. 40 to 60% of patients will end up on dialysis in 10 to 20 years. It does not respond to steroids. And as I just said, a severe version of minimal change disease is an easy way to remember many of the features of FSGS. FSGS is particularly common among African Americans. It's the most common cause of nephrotic syndrome in this demographic. Shown on the table on the screen are the causes of nephrotic syndrome among African Americans and Caucasians. In the African American group, FSGS is the most common cause. Among Caucasians, the most common cause is membranous nephropathy, which we'll talk about in a few slides. Usually FSGS is an idiopathic or primary disorder. However, there are many secondary causes that you need to know for step 1, so let's review those now. FSGS can occur in patients with HIV, sickle cell anemia. It can also be seen among patients who use heroin. FSGS is also associated with massive obesity. It can also be seen in patients receiving interferon treatment. Interferon is used to treat chronic hepatitis C and hepatitis B viral infections. Interferon is also used to treat some leukemias and lymphomas and sometimes to treat melanoma. And then finally, FSGS is associated with loss of nephrons. For example, patients born with a congenital single kidney or patients who have had a surgical kidney removal are at increased risk for FSGS. Our next cause of the nephrotic syndrome is membranous nephropathy. This disorder gets its name because in membranous nephropathy there is thickening of the glomerular basement membrane. If you look at the bottom left side of the screen, there's an example of a normal glomerulus. If you look at the bottom right side of the screen, there's an example of a glomerulus from a patient with membranous nephropathy. Note that the glomerular basement membranes are thickened as indicated by the arrow in the bottom right side of the screen. Importantly, in membranous nephropathy, the glomeruli display an absence of hypercellularity. Why is this feature so important? Well, if there was hypercellularity within the glomerulus, then the disorder would not be membranous. It would instead be membranoproliferative glomerulonephritis. That disorder gets its name because in membranoproliferative glomerulonephritis, in addition to thickening of the basement membrane, there is hypercellularity of the glomeruli, hence the name proliferative in the title of the disorder. The reason the membranes are thick in membranous nephropathy is from immune complex deposition. Antigen-antibody complexes deposit in the basement membranes of glomerular capillaries in membranous nephropathy, and that leads to the nephrotic syndrome. Because immune complexes are involved, immunofluorescence microscopy is very useful in membranous nephropathy. It will demonstrate granular deposits of IgG and C3 in renal biopsy samples. This is an example of granular staining shown on the screen here. If you focus on the left side of the image, you see a bumpy appearance to the immunofluorescence antibodies that are lighting up. That bumpy appearance is happening because there are immune complexes deposited in that region of the glomerulus. On a pathophysiologic level, what's happening in membranous nephropathy is that immune complexes are depositing in the subepithelial region, in other words, below the podocytes. I've shown that with these purple markers here on the screen. They are below the podocytes on top of the basement membrane, and it should make sense to you that this is where the immune complexes deposit. When they deposit there, they disrupt the filtration barrier to protein and lead to the nephrotic syndrome. If the immune complexes were deposited below the endothelial layer, they would disrupt the capillary endothelium, and that would lead instead to the nephritic syndrome. Because of the immune complex deposition, the podocytes lay down extra basement membrane on top of the immune complexes. This leads to a pattern known as the spike and dome pattern. In other words, the new basement membrane will look something like what I've drawn on the bottom of the screen here. It will have bumps or domes over the immune complexes and spikes in between those domes. This leads to the spike and dome appearance. The characteristic electron micrograph finding in membranous nephropathy is the presence of electron-dense deposits. If you look at this picture on the screen here, the middle of the picture is the capillary lumen. Bowman space is out here. You can see these dark spots. These are subepithelial immune complex deposits. Those are called electron-dense deposits, and those are characteristic of membranous nephropathy. The other characteristic biopsy finding is presence of the spike and dome basement membrane. This is best seen with silver staining like I've shown on the screen here. If you focus on the edges of some of these glomerular capillaries, you can see little spikes like what I'm marking with my pen here. Those spikes are pieces of basement membrane that have been laid down between immune complexes. So just to summarize the renal biopsy findings in membranous nephropathy, on light microscopy you see capillary and basement membrane thickening. On electron microscopy you see subepithelial deposits, those electron-dense deposits. And on immunofluorescence staining you see a granular pattern, especially when stained for IgG and C3. Membranous nephropathy is often idiopathic, meaning it is not related to any other systemic disease that is triggering the production of antibodies. In the idiopathic form, autoantibodies are found against antigens called phospholipase A2 receptor, or the PLA2 receptor. This antigen is expressed on podocytes, and therefore it should make sense to you that autoantibodies directed against this podocyte antigen could lead to the nephrotic syndrome. There are a number of secondary causes of membranous nephropathy, and one of the important ones is lupus. Now, most lupus renal disease leads to the nephritic syndrome. In the nephritic syndrome video, I talk in detail about diffuse proliferative glomerulonephritis, which is the most common form of renal disease among patients with lupus, and it leads to the nephritic syndrome. However, if patients with lupus develop the nephrotic syndrome, then the cause is usually membranous nephropathy. This happens to about 10 to 15% of lupus patients who develop renal disease. And you know that lupus is associated with antibodies, so it should make sense to you that those antibodies could potentially deposit in the basement membrane and lead to membranous nephropathy. Membranous nephropathy can also occur in patients with solid tumors, especially colon cancer, lung cancer, and melanoma. It can also be seen in patients who have viral infections, especially hepatitis B and hepatitis C. And finally, it commonly occurs in patients taking certain drugs. These drugs are all used to treat rheumatoid arthritis. They include penicillamine, gold, and NSAIDs. And an easy way to remember this is just to remember the phrase tumor, hepatitis, and rheumatoid arthritis. It rhymes, and these are the three secondary causes of membranous nephropathy that you should know other than lupus. Membranous nephropathy is the most common cause of nephrotic syndrome in adults. Shown on the screen is a table I showed earlier indicating the causes of membranous nephropathy in African Americans and Caucasians. Among Caucasians, membranous nephropathy is the most common cause of the nephrotic syndrome, and therefore it's also the most common cause overall among adults. Age is a very important prognostic indicator in membranous nephropathy. This disorder has an excellent prognosis when it occurs in children. The prognosis is worse among adults. Some adults who get membranous nephropathy go on to develop end-stage renal disease. A brief word about autoantibodies. Most antibody disorders lead to the nephritic syndrome. In the video on the nephritic syndrome, I talk about a number of different disorders where immune complexes form. These trigger inflammation. That leads to nephritis, and nephritis leads to the nephritic syndrome. Membranous nephropathy is unusual in that it involves autoantibodies, but it leads only to the nephrotic syndrome. The reason for this is because, as we have been discussing, the deposits are subepithelial, and therefore they disrupt the podocytes and they lead to the nephrotic syndrome, but they do not trigger inflammation, and therefore they do not lead to nephritis. Diabetes can potentially cause the nephrotic syndrome. In diabetic nephropathy, there is non-enzymatic glycosylation of basement membranes. This leads to leakage of proteins. The long-term effect is sclerosis of the glomerulus. Many diabetics develop proteinuria, and the proteinuria can progress, and potentially diabetic nephropathy can lead to the nephrotic syndrome. Amyloidosis can also potentially cause the nephrotic syndrome. I talk about amyloidosis in detail in one of the videos in the hematology section. It involves the extracellular buildup of amyloid proteins. The classic biopsy finding, whether you biopsy the kidneys or any organ involved in amyloidosis, is the appearance of apple green birefringence on Congo red staining. And you should always remember that the kidney is the most commonly involved organ in systemic amyloidosis. So let me finish by going back to our 6 causes of the nephrotic syndrome. Remember that in all of these disorders, something is disrupting the podocytes and the basement membrane, but leaving the capillary endothelium intact. That leads to leakage of proteins, but not leakage of red cells, and therefore the nephrotic syndrome occurs and not the nephritic syndrome. So in minimal change disease, cytokines disrupt the podocytes and lead to effacement of the podocytes. In FSGS, there's an unknown trigger that leads to podocyte damage. In membranous nephropathy, there are immune complexes which damage the podocytes and basement membrane. And then finally, in diabetes and amyloidosis, either glucose or amyloid proteins are damaging the podocytes and the basement membrane. And that concludes our module on nephrotic syndrome.